The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name is Mark Ryan, and it's a pleasure to be hosting the podcast, and thanks to everyone for listening in. So on February 21st and 28th, I did two podcasts discussing the need for drug price reform. I thought it would be good to cover once again another topic here that I've covered in the past about the crying need for medical service price reform in our healthcare system as well. So today's topic is really titled, Medical Pricing is as Broken as Drug Pricing. American healthcare is in dire need of price reform, as is employers are significantly disadvantaged the way things are today. We'll take our normal 3 breaks and split up the podcast. So let's get right into a brief intro of the subject before our first break. So medical price reform is key as employer coverage costs are very much out of control. As you know, America has the only employer-driven healthcare system in the developed world. As I say often, there are 3 healthcare models out there in the developed world. Socialized medicine, a good example is the United Kingdom. This is where the state pays for, manages, and runs the entire system of care for the most part. Second, there is a single-payer system out there. A good example is Canada. Another one is France. And in this one, the government pays for and oversees the system, but the care is largely delivered in the private sector for the most part. And the third major developed world system is private universal access. And good examples here are the Netherlands and Germany. And in this model, the government pays for some care and regulates the system, but the private sector otherwise runs and provides the actual care in the system. Is one system better than another? Well, I often tell you about the Commonwealth Fund study of developed world healthcare systems that finds that really all 3 systems can be efficient and provide great quality. And the problem with the American system, as Commonwealth Fund has found, is that it's the most expensive, well more expensive than the most expensive other developed world systems, and it has the worst quality. And in fact, our quality is an outlier even against the lowest performing systems in the rest of the developed world. So we don't really have any of the models in America, as we don't have universal access. We have a very large number of uninsured. We have taken some strides to get to more of a private universal access system by passing the Affordable Care Act or Obamacare. But again, we still have many uninsured and many gaps in the system. But back on our topic of today about medical service pricing, employer coverage is roughly the majority of all coverage in America. About 165 million people are covered by employer coverage each year. While Americans complain about it, most people pretty much like their employer-sponsored coverage, or at the very least, they don't support the alternatives and they're afraid of single-payer or socialized medicine. And although employer coverage is a burden on our business, we do have much higher productivity in the United States compared to the rest of the developed world, which really helps close the competitiveness gap that would otherwise be there because of the big costs that businesses are taking on with employer-sponsored coverage. But rising healthcare costs are hurting our competitiveness for sure. I've made the case that employers in America have a disproportionate cost burden compared with businesses in other developed nations. That is because even with tax deductibility of healthcare costs, employers pay a disproportionate burden of healthcare costs due to our predominantly employer-sponsored system. Foreign companies just don't have this. There is little doubt that U.S. employers could reap huge savings and therefore be more competitive if we did two things. First, equalize payments across all lines of business, Medicaid, Medicare, and various commercial lines, including employer coverage. And two, implement site-neutral payments. The two together could save hundreds of billions of dollars, rationalize our system, encourage even more efficiency throughout the system, and lower employer healthcare costs. So with that, we'll take our first break before we get into price disparity between lines of business and how to solve that through equalization. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this edition of the Healthcare Labyrinth podcast. We're talking about medical price reform, and we introduced the topic of the need to really equalize payments across all lines of businesses for medical services so that the impact on employer coverage and businesses could go down. So let's get right into that issue of price and cost disparity between lines of business. Excessive employer coverage prices are generated by Medicare and Medicaid actual and perceived underpayments. While providers could be more efficient, there is some evidence that government programs tend to under-reimburse in some cases. Adopting uniform pricing across lines of business would stop a cost shift to the employer world. What do we know about provider rates in various lines of business? Well, let's talk about Medicaid versus Medicare. Medicaid rates generally are the lowest. It is hard to obtain exact payment rates in Medicaid, principally because reimbursement can vary greatly by state and even among healthcare services. In general, according to the Kaiser Family Foundation, Medicaid rates are almost 30% below Medicare rates across the board for all Medicaid types of services. MACPAC, the congressional policy arm for Medicaid, says Medicaid inpatient hospital rates are found to be about 22% below Medicare rates. But many states provide supplemental reimbursement on the hospital side to close that gap. So hospitals generally are usually compensated in Medicaid in some states much better than other providers. Accounting for these payments to the hospitals that are supplemental, inpatient Medicaid rates actually can be about 6% above Medicare rates. But I would note here again, not all states offer such payments, and supplemental payments may be funded by provider taxes as well. Let's talk Medicaid rates versus cost. I am often dubious of statistics from hospital lobbies, but the American Hospital Association tells us that hospitals received payment of only 88 cents for every dollar spent by hospitals caring for Medicaid patients in 2020. It is unclear if all supplemental payments are included or not in that figure. Given the power of the hospital lobbies in states, it is fair to say that the gap between cost and payment can be greater for other types of Medicaid providers beyond hospitals. Let's now talk Medicare versus cost. The AHA again indicates that hospitals and Medicare received payment of only 84 cents for every dollar spent by hospitals caring for Medicare patients in 2020. In general, Other Medicare provider rates are more robust than in Medicaid, and gaps between service types in Medicare between hospitals and other providers is probably less than they are in Medicaid. Let's talk Medicare rates versus commercial rates now. Studies find that commercial physician rates are 130% to 145% of Medicare rates. For inpatient care, rates range from 185% to 255% higher than Medicare. Outpatient hospital commercial rates can be as much as 290% more than Medicare. So what can we conclude on price differences across lines of business? Well, the figures I just told you paint a picture of some possible under-reimbursement in government programs that may need more government money to stop that cost shift to commercial. More importantly, what the actual and sometimes perceived under-reimbursement in Medicaid and Medicare does is allow providers, notably powerful hospitals, to pursue and justify a policy of demanding and achieving over-reimbursement in commercial and employer coverage. I use the word actual or perceived under-reimbursement because a case can be made that Medicare and Medicaid rates may be adequate for most providers, especially hospitals. The nonprofit think tank The Third Way concluded that 55% of U.S. hospitals make money on Medicare payments, with 33% making money on Medicaid payments as well. The efficient hospitals made money in Medicare by keeping costs down, saving almost $4,000 per patient discharge, $12,000 for those making money versus $16,000 for those that did not. Of those that made money, most of these hospitals made 10% or less on Medicare. In contrast, most hospitals that lost money on Medicare had significant losses of over 10%. So the more hospitals spend, the worse they are. Third Way also gives us a glimpse of where commercial profitability might be for hospitals. At Duke Regional Hospital in Durham, North Carolina, the hospital makes money on both Medicare and Medicaid rates. The break-even point for commercial might be somewhere about 154% of Medicare. It charges about 258% of Medicare and makes a 35% profit on commercial insurance. Third Way says that commercial rates for hospitals are a nationwide average of about 254% above Medicare. Extrapolated across the nation, that difference in rates, 258% in commercial versus 154% break-even of Medicare, could be worth hundreds of billions annually to the healthcare system. Now, hospitals deserve a margin too, but let's remember that health plans make 5% to 10% in a good year, so 35% margins at hospital on the commercial line of business are very high. Hospitals could make a margin on commercial that is reasonable at much lower commercial rates and huge savings to the nation. By the way, it's not just providers who game the system when it comes to price. It is health plans too. And all this disadvantages employers when it comes to costs. We'll cover that when we get back from the second break. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back. We hope you're enjoying this episode of the Healthcare Labyrinth podcast. We've been talking about price disparity between Medicare and Medicaid, government programs, and commercial. And I made the case that maybe there is some under reimbursement in Medicare and Medicaid, and that's causing a cost shift over to commercial. And the truth is, hospitals probably could, most of them could make money on Medicare and Medicaid and afford to have much lower commercial rates as well and still make a profit. But the fact that we may under reimburse a bit in government programs gives hospitals and other providers an excuse to jack up commercial rates and not be very efficient. And I told you right before the break that it's not just these hospitals and other providers that are driving up commercial rates, but the truth is health plans are doing that too. That may surprise you, but let me explain that. Health plans generally contract at or near Medicaid fee-for-service rates in the Medicaid program, given how low the rates are from states. They may supplement a little and leverage their relationships with providers and other lines of business to help network adequacy. But health plans play a really ugly game when it comes to negotiating commercial rates versus Medicare Advantage rates. The vast majority of commercial coverage is self-insured by employers, where health plans act as an administrator of healthcare services for a set fee. Plans are not at risk for employer coverage usually for the medical expense or the rates they pay in the self-insured employer coverage market. The truth is, employers are at risk. But in MA, health plans are at risk and rates they pay to providers are everything. Health plans want to maximize margins in this usually high revenue and high premium line of business, Medicare Advantage. Thus, what health plans do is trade higher rates in the employer coverage world in favor of maintaining rates that are close to Medicare fee-for-service for Medicare Advantage. The higher costs in the employer world are covered by employer self-insured funds, and employers usually are none the wiser. So the cost shift is actually encouraged both by providers as well as health plans, given how most employer coverage is funded in the nation. Plans and providers each have a role in driving up employer coverage costs by demanding and agreeing to excessive commercial rates. So back to equalizing price. This would mean some additional spending on the part of government programs, but overall costs would be more rational and come down over time, in my view. Prices would be the same across all lines of business. Providers could not seek higher employer coverage rates. Plans would not be able to agree to high commercial and employer rates to favor their MA lines. Providers also would be forced over time to be more efficient with a much more transparent pricing system. Right now, given how hospital rates are set for commercial and employer coverage, we really have no way of doing that. So let's move on to our second area of price reform, which is site-neutral payments. Moving beyond lines of business, hospitals fight for favorable payments in Medicare by demanding excessive compensation for services performed in hospitals or hospital-owned settings when these same services are reimbursed lower at cheaper settings, such as physician offices or ambulatory surgery centers. Hospital outpatient settings, hospital-owned freestanding ambulatory centers, and hospital-owned clinics often are reimbursed more via straight rate setting based on their place of service or by an additional facility fee levied by the hospital owner for that service. While some small reforms have been made, hospitals continue to be reimbursed exorbitantly for services they perform at hospital-based or owned settings. that can be done much more cheaply in other settings. The problem is exacerbated by the fact that hospitals and health systems are buying up physician practices. About half of all doctors today work for hospitals or health systems, and studies show these doctors' practice patterns are changing to having procedures at more expensive hospital-based or owned settings. Mandating site-neutral payments in Medicare would save up to $145 billion over 10 years if fully applied. But commercial reimbursement and therefore employer costs are impacted by the lack of site-neutral payments in Medicare because most commercial payments are primarily a percentage of Medicare rates. A Blue Cross and Blue Shield Association study finds the following. Average prices paid for a large commercial population were 31% higher for clinic visits in 2022 when provided in a hospital outpatient department setting compared with a freestanding physician office. Average prices paid for a large commercial population were 238% higher for chest x-rays in 2022 when provided in a hospital outpatient department setting compared with a freestanding physician office. Average prices paid for a large commercial population were 563% higher for prostate biopsies in 2022 when provided in a hospital outpatient department setting compared with a freestanding physician office. The Blue Cross and Blue Shield Association says migrating completely to site-neutral payments in the healthcare system would save $471 billion for the government, Medicare, private insurance premiums and costs, because they are based on Medicare rates, and Medicare patients in cost sharing over 10 years, 2024 to 2033. Some studies say the savings could be as much as $847 billion over that time frame. With that, we will take our third break and we'll come back with some concluding remarks. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We've been talking about the need for medical price reform. This is especially important because of the high cost in the employer coverage world and the fact that they continue to go up very robustly. So let's talk about the solution again. Providers live off high rates and have no impetus to be efficient. Health plans' conflict of interest in negotiating rates for employer groups perpetuate the problem. Equalizing rates across all lines of business with a reasonable margin built in is the answer. As well, immediately implementing site-neutral payments across all services would add to savings. All this would take away the hospitals' or other providers' excuse to demand over-reimbursement from commercial and employer coverage, thereby reducing the costs to employers and making them far more competitive throughout the world. The additional benefit would be equal access to providers, regardless of how your insurance is provided. Further, the system would emphasize efficiency and outcomes throughout the healthcare system. So with that, we will end this episode of the Healthcare Labyrinth podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.